Thank you for your interest in my research. My programme of research explores inequalities within mainstream child and adolescent mental health services for autistic children and young people and children and young people with intellectual disabilities. Before I begin, just a little bit about me and why this work matters to me personally and professionally. I'm a social worker within NHS CAMHS and a doctoral researcher at the University of Warwick. I bring what Professor Owen Kalaki describes as lived, loved, laboured and learned experience into this work. For me, this research is not just about data or systems, it's grounded in real experiences of children, young people and families navigating mental health services. And importantly, to my knowledge, this is the first mixed method sequential doctoral study of its kind in England examining mainstream CAMHS access for autistic children and young people and for children and young people with intellectual disabilities from multiple perspectives. Autistic children and young people are 4.5 times more likely to experience high rates of anxiety, depression, and to self-harm than their neurotypical peers. 40% of children and young people with intellectual disabilities have a diagnosable mental health condition. Despite this, many continue to face barriers when attempting to access mainstream mental health support. Previous research has identified diagnostic overshadowing and long waiting lists for mental health support as factors in preventing this population from accessing services earlier. However, much of the existing literature is not based on primary research and does not include children and young people with intellectual disabilities. I used a mixed method sequential design across 5 interlinked work packages. The research began with lived experience narratives from children, young people and their parents, then moved into a national clinician survey across CAMHS services, followed by senior stakeholder interviews across healthcare, education and social care. These findings were then integrated through the pillar integration process before finally being translated into co-designed practical guidance with lived experience and professional contributors. The first work package focused on lived experience. The aim was to understand both the experiences and support needs of autistic children and young people, including some with co-occurring intellectual disabilities and their parents, when accessing mainstream child and adolescent mental health services for mental health support. I wanted to move beyond simply asking whether services were accessed and instead explore what those journeys actually felt like for these families. So the research questions focused on 2 areas. Firstly, experiences of seeking and receiving support, and secondly, what children and young people and their parents felt they actually needed from services when experiencing mental distress. In total, this work package included 56 narrative interviews with 7 autistic children and young people, some of who had a co-occurring intellectual disability, and 12 parents. The data analysis took place in 2 stages. In stage 1, I used thematic analysis, and in stage 2, these themes were synthesized into composite narratives to preserve emotional meaning while protecting anonymity. Ultimately, the composite narratives enabled me to move beyond fragmented thematic extracts and instead present the lived realities of navigating mental health systems in a way that remained coherent, relational, and grounded in the participant voice. The narrative interviews focused on 3 areas: recognition and signposting, access and assessment, and the therapeutic relationship. Parents were encouraged to tell their stories, reflecting on how they understood their child's distress and their experiences of accessing mental health support. An example of an excerpt taken from a parent composite narrative made up of 4 parent narrative interviews on barriers goes as follows. Doctors kept saying we can't help because she's autistic, or it's not mental health, it's autism, but autism and mental health are not mutually exclusive. The referral was confusing and contradictory. We were referred 4 times and rejected 3 times. Sessions were inconsistent, with different therapists employing varying approaches. Natalia would begin opening up before being assigned another therapist. Her improvement came despite CAMHS, not because of it. The children's narrative interviews were adapted to support accessibility, communication and participation for autistic children and young people, including some with co-occurring intellectual disabilities. So rather than relying solely on verbal interviewing, children were offered a range of play-based and creative approaches, including drawing, playing with dolls, and using emotion stones. I used a story stem approach, where I began a fictional story and the child showed or told me what happened next, using their preferred communication style. Visual supports included social stories, Makaton symbols, and repeated summaries to scaffold communication and support recall. Importantly, the focus was not simply on adapting the interview method, it was also about creating a relational and flexible space where children could communicate in ways that felt meaningful and safe for them. And here's an example of one of the composite narratives that were created from the children.
Through the story of a fictional character named Luna, composite child Jessica described experiences of bullying and emotional distress. Luna's parents helped her seek support from a helper. In the story, the helper listened carefully and suggested strategies while managing difficult feelings. Luna used activities such as drawing and meditation to calm herself. As the story progressed, Luna began to feel calmer and happier. It's calm and peaceful now. The helper listens to her. Composite child Jessica's narrative emphasized the importance of feeling heard and supported by trusted adults.
Work package 2 explored clinician perspectives through a national CAMHS survey involving 135 clinicians across 19 NHS trusts in England. The survey was adapted from existing measures developed in the US and Canada, but importantly, this study extended the focus beyond autism to also include children and young people with intellectual disabilities, an area where there is very limited evidence. The survey examined clinicians' reported knowledge, confidence, skills and adaptations used when delivering psychological therapies, alongside questions about triage, referral pathways and access criteria within mainstream CAMHS. Data analysis was conducted using SPSS, using non-parametric statistical tests. This allowed the study to identify where significant differences in workforce capability and service confidence existed across populations. The survey findings demonstrated important workforce challenges with mainstream mental health services. Clinicians consistently reported feeling less prepared to support autistic children and young people, and particularly children with intellectual disabilities, compared to children and young people without an autism or intellectual disabilities diagnosis. Importantly, clinicians themselves identified the need for additional training and supervision to support practice. The findings suggest that workforce limitations are systemic rather than individual failings. Work Package 3 involved 14 senior professionals across healthcare, social care and education. This work package moved beyond individual experiences and explored the system itself, specifically how senior stakeholders responsible for commissioning, policy, pathway planning and service delivery understand access to mental health support for autistic children and young people and children and young people with intellectual disabilities. I used online mini focus groups and paired dyadic interviews with stakeholders. This allowed participants to challenge, build on and reflect together on the realities of service provision. The study explored key questions around policy, legislation, workforce training, accessibility, commissioning priorities, and whether systems genuinely distinguish between autism, intellectual disabilities, and mental health needs when designing services. The data was analysed using reflexive thematic analysis. For Work Package 3, stakeholders described services operating under significant economic and workforce pressure. They highlighted restrictive thresholds, postcode variation, and fragmented interagency working, and diagnostic-led pathways that often delayed support until crisis point. One stakeholder reflected, "It's complicated enough if you work in the system, let alone if you're a parent or a child." Importantly, many participants felt current systems were not designed around the lived realities of autistic children and young people and children and young people with intellectual disabilities. Across Work Package 3, stakeholders consistently described barriers as interconnected rather than isolated. And this raised an important question for me. What happens when we integrate lived experience, clinician perspectives, and system-level insights together? So in Work Package 4, I integrated all the findings systematically. 6 integrated anchors emerged. What became clear through integration is that these barriers reinforce one another. Workforce limitations contribute to gatekeeping. Gatekeeping delays intervention. Delayed intervention increases crisis presentations. And then fragmented systems place additional burden on families trying to coordinate support. So these inequalities are not just isolated service failures, they are emergent properties of the system itself, which means isolated fixes are unlikely to create meaningful change. In Work Package 5, I focused on patient and public involvement and engagement activities. This involved 60 contributors, including parents, children and young people, and professionals. The aim was to translate findings from the wider programme into practical recommendations for mainstream child and adolescent mental health services. Through collaborative discussions, contributors identified barriers across triage, assessment, treatment, and discharge pathways, and co-developed an open science framework design to improve accessibility, inclusivity for neurodivergent children and young people. A key principle underpinning this work was recognising lived experience as expertise. Importantly, contributors were not positioned simply as consultees, but as active partners in shaping recommendations for practice. The recommendations centred on a key shift from diagnostic-led approaches towards needs-led approaches. Following the 5 interconnected work packages, I was able to create an illustration that demonstrates how barriers interact as a feedback loop rather than existing independently. The findings from this programme of research have important implications for mainstream child and adolescent mental health services. Across all work packages, one message remained consistent. Many autistic children and young people and children and young people with intellectual disabilities are only accessing support once they reach crisis point. This suggests that crisis is often not a sudden event, but the cumulative outcome of unmet need, fragmented pathways, and delayed intervention. Ultimately, the programme provides not only evidence of inequality within systems, but a foundation for future system-level innovation. And perhaps most importantly, it reinforces the central message running throughout this presentation. We do not need to change the child, we need to change the approach. Future work now needs to move beyond simply identifying barriers and towards developing, implementing, and evaluating solutions that create genuine, accessible mental health systems for autistic children and young people, particularly children and young people with intellectual disabilities.